when it comes to peripheral arterial disease, what's interesting is most people don't even know that they have it. That's the tough part. And it's the same thing for providers. Most providers don't know that they have, that their patients have it. And then for those that have it, a good number will have what we call atypical symptoms. Well, these are symptoms that are not classic. These are symptoms that don't fit the narrative in the textbook, but they have the process. And then we have those that develop claudication, which would be about 18% that's worsening, and at time that still get missed because either the patients don't know or the providers don't know. And then we have 1 to 2% of the folks who unfortunately will develop critical limb ischemia, which means the end stage of peripheral arterial disease. Those are the folks that present with wounds, gangrene, ulcerations, or rest pain. And unfortunately, they can progress to amputation if not addressed in a timely fashion. And addressing it requires medications. It requires opening up of the arteries and ways to do that, whether with balloons and stents like Dr. John Phillips and I can do, or with combination of surgery and ballooning and stents, or sometimes surgery alone. But it requires replenishing blood flow. And sometimes it doesn't happen in a timely fashion. We know there's some facets of the population that sometimes do not have access to care, which can lead to all these issues. So really what's important here is for all of us to get together and say, what can we do to make this better? Do we know what to do? We're still learning. And we're always going to continue to learn. But in the meantime, what can we do to make sure that everybody that we come across has access to care so we can help? But the challenge that I find is explaining exactly what this means. So I'm going to share my screen. What I want to share here is when we talk about critical limb ischemia, we know about 2 million people are facing this problem in the US, and about 25% could potentially require an amputation, and 56% will be dead within 5 years. And it's well established that disparity exists in underrepresented communities, and the multiple factors affecting this that includes conscious or unconscious bias, systemic inequalities, and imperative to improve these outcomes. This slide is really, really, really important to me. As you can see, I just want to show a comparison. When we talk about breast cancer, so every October, everything is lit up pink around the country, which is great because it means our colleagues treating breast cancer patients have done a great job of getting their message across. But when you look at our patients, so people that have Charcot foot, which happen to a lot of diabetic patients, patients with diabetic foot ulcers, and then you compare with a patient with critical limb ischemia, the mortality is much, much higher. So breast cancer over the next 5 years, approximately 11% of patients will pass away, which is not good. We still have a lot of work to do that. But when you look at patients with chronic limb ischemia, diabetic foot ulcer, or people that get major amputation, really the only thing that stands out is lung cancer. So this is the equivalent of a cancer, but we don't approach it that way. So hopefully this gives us an opportunity to empower the community, to empower our patients, so we can make sure that we're seeking the proper care for the patients facing this. Some of the issues affecting this and this outcome are social determinants of health. This is a slide that I used to present a year or so ago, courtesy of Dr. Felucia Fakorudi in Mississippi. So we have to address economic stability, so employment, income, access to good health care, and we need to make sure we address neighborhood and physical environment, so housing, transportation, parks, playground. The more active we are, the less likely we are to develop diabetes, hopefully. And if we do, hopefully we can manage it well. We know there's certain zip codes that have less access to care or to the best care. Education becomes really important. I think it's a cornerstone of what we need to do to educate the community, to educate our patients, to also educate the medical community as well on how to address this issue. And we talk about food. Somebody mentioned food earlier. I cannot stress how important it is to eat the proper diet, to eat more vegetables, to minimize processed food. But sometimes that's all people have access to. Or if you have to work two jobs, you might not have enough time to spend an hour or two in the kitchen to cook. All those things can affect that. And then we have community social context, so social integration, system support, community engagement, and then overall healthcare system. So we have a lot of work to do, and that's why it's important to have a seat at the table to make sure that we can communicate with the community to bring everybody together to improve the healthcare of everybody. And there's certain communities, certain populations that are at risk. And when you look at peripheral artery disease, we can see looking at this graph that African Americans, both male and women, have a high risk. So it becomes incumbent upon us really to address this issue early on, to address the risk factors before people fall into that 1% to 2% population with limb ischemia facing an amputation. And guess what? This is going to get worse over time. Why? Because the population is getting older, obesity is a problem, so we anticipate diabetes is going to get worse. Unfortunately, the outcome could potentially get worse unless we as a society do decide to take an action that's different than what we've done historically. I want to share this particular slide. This is the paper that was published by our colleagues in California. They just looked at the number of people that were amputated between 2011 and 2017. 80,000 people needed a major amputation. These were non-traumatic amputations. And they broke it down by age. They looked at between 45 and 64, which is working age, and they looked at 65 and above. And you can see here, when you put it by race, so for those who are younger than 65, the risk of getting amputated, this is for whites, and this is for Hispanic, and this is for Black counterparts. You can see there's a drastic difference, 3 to 4 times higher. As you get older, same thing. This is white counterparts. We don't want to see this either because a lot of these amputations are probably unnecessary. But when you look at Blacks and Hispanics, you can see the gap. How can we fix this? When you look at the association between race and the risk of amputation or lower extremity, same thing. You can see whites here, African Americans, you can see Native Americans. This is a big gap. And these are all of us living here in the US. So we're in the same playground, but our outcomes are not the same. Now, you can look at things differently. We say, okay, let's put race on the side because sometimes you can get very sensitive. Let's just look at it by income, right? So when you start looking at income, so you have whites and non-whites, you can see the difference between amputation rate. And when you start looking at income, as your income change, you can see those with low income level have a much higher rate of amputation compared to those that have a higher income. And interestingly here, when you look at here, when you compare private insurance, those with and those without, drastic difference. So it means those that don't have access to good insurance are suffering. And how can we fix that? And then you can look at this and say, okay, let's look at this outside the US. Let's put race on the side. Let's go to a country like Scotland, fairly homogeneous. The same thing. When you look at the rate of amputation, it goes higher as your quartile of income decreases. So this is a disease of neglect. The less money you have, the less access to care you have, the likelihood your amputation is going to be higher. How can we fix this for fellow mankind? And when you look at the amputation rate within areas where high population of African Americans or underrepresented minorities, you can see amputation rate in the US, darker, that means the higher. And when you look at here, this is the largest population of African Americans in the US, and same thing in these pockets where you have this high amputation rate. So there are a lot of work we can do. One can argue, okay, maybe this is happening in rural areas. But when we look at big cities, same thing. You go to Philadelphia, you can see here, you go to Detroit, same thing. The area where you have the highest density of underrepresented minorities, that's where you have the highest area of amputation. Those are also the area you have the lowest type of insurance or the lowest income. So can we make a difference? The answer is yes, we can make a difference, but I think it's important how we approach this, how we address this issue. And when I want to look at this 1 or 2 slides last, looking at the US Census population. So as of now, if you look at adults in the US, this is the majority. We have whites here, we have Hispanics, we have Blacks, we have Asians, we have Native Americans, and multiracial. These are adults. But when you look at our children, it's different. So more than 55% of kids in America identify themselves either as minority or mixed, which is not the same as adults, which means our population, our society is changing. At a minimum, we owe it to our children to do better, because as they're getting older, we're going to have to find a way to treat them. And so as we're changing, we need to make sure that we have seats on the table. We need to make sure we have a pipeline of physicians that are going to address this issue. And if you look at clinical trials in America, so even though this is the US population of whites, right here is Hispanics, you have African Americans, you have Asians. But when you look at clinical trials, so even when we're gathering information, the information that we're gathering might not even apply to the folks that we need to treat or is reflective of our population. So there are four things we can look at: patient factors, systemic factors, provider factors, and science factors. And all of these things that we need to look at really should be centered around our patient, so we can provide a patient-centered care that's going to give the best outcome for everybody. And really, all of us need to be at the table to do this. And so the individual level, interpersonal level, institutional level, and policy level. And if we can combine all those things, we can make a difference. I just want to share the very last slide here. This is a trial I was not involved with, but we followed very, very closely. And among the things that they did that really helped was to look at the disease prevalence, understanding patient population, set up a trial that included everybody, be intentional about getting clinical sites, physicians, family involvement, so that way you can have a good outcome and a good representation. And there's another trial that we participated when I was in Louisiana before I moved to Florida. And one of the things that we did better than we had done historically is we had 48% of underrepresented minorities, which is usually not the case. And we also had 40% women, which is usually not the case. And I think among the many things that helped is the people that were involved in the trial. My partner, Dr. George Youssef, Dr. Samani, Dr. Punia, and myself, all of us underrepresented minorities. Between the four of us, we all spoke at a minimum 3 languages. And of all the languages that we spoke, we covered the top 5 languages spoken in Louisiana. So we're able to get access to people that perhaps historically did not get access to, and we brought them to enroll them in a trial to get information. Hopefully, that will make it for a better future. So this is my last slide of the day. I want to share this with you, that if we can bring people on board, if we can have access to the best care, clinical trials, hopefully we can have information to make a difference among the many things I just shared with you this morning.